All right. Everyone's coming back. Good evening again. If you would place your name and campus in the chat once again. The last exam is on Friday. So, and the exam analysis will occur on Friday as well. So grades will be posted Friday afternoon after the last class takes their exam. And as you know, nothing's new. We don't give out preliminary scores and things like that. So, but the last class takes their exam on Friday, and then we do the exam analysis shortly after that class finishes. And then grades will be posted thereafter. So let's look and see where we're at. The next exam comes up pretty quickly, wow. It comes in week 7. Let me look and make sure. Telling you all correctly. Okay, I will share my screen here. All right. So let me share my screen. So for those of you out that are just coming in, make sure you place your name and campus in the chat again. As I mentioned, the last class take their exam on Friday, and the exam analysis will take place shortly after. Then grades will be posted then. So we're here in week 4. We just took unit exam 1. So then we meet next week. We take quiz 3, and then we cover all of the content. And then we have the exam 2 in week 6. So just to let you know where we're at. After the first exam, things go by pretty quickly. So make sure that you're looking at your schedules, rearranging, deleting, putting things on pause, looking at your whole picture. Consider family, schoolwork, your clinical. Some of you will have clinicals. So just go back and look at that calendar pretty often and see what things you can do differently, because this time goes by pretty fast. And so reach out if you're having any issues or concerns about anything. All right. And so we're going to move on with our content here. Let me share my screen. So we have this thing called the Nurse Practice Act. So it guides us from the beginning. It's like our to-do list. It guides us as what we can lawfully do, and it keeps us to allow us, well, it shows us the things that we can do so that we won't do anything that's unlawful. And it's guided by the state statutes, and it is considered the law. The Nurse Practice Act, it is considered the law. Now, what facilities and just make sure we're recording, what facilities do, they take the Nurse Practice Act and they revise or compose their policies and procedures from the Nurse State Practice Act, because they should not be asking us to do anything that's not on our to-do list. Because if it's not on our to-do list, we are breaking the law. So the Nurse Practice Act is guided by the state statutes, and it is considered the law. It's a guideline of what actions, those things that we can lawfully do. And so that you want to refer to that. Even once you get your licensure and you are multi-state licensed, if that's what you so choose to do, make sure you look at each state Nurse Practice Act, because they're not all the same. So, and that is your guideline. If you are being asked to do something at your job and it's not on your list, on your to-do list, your Nurse Practice Act list, then you should not do those things, because will be committing a crime. So it is guided by the state statutes, and it is considered the law. It is a guideline that guides our actions. It tells us what we can do and not do. The functions of the state board, nursing general provisions here. The state board is like this governing body. It goes over the general procedures, the licensure process. We do need to know that part. It also guides and give guidance and reprimands on unprofessional conduct as well. So it does the state boards, they also function, they define what nursing is. They help come up with that Nurse Practice Act based on the evidence. And then it does approve new nursing programs, and they provide that oversight for those nursing programs. In addition to that, you will have to complete continual education units, as we call them CUs, and there are different numbers in order to keep your licensure current, and they also oversee that part. As a matter of fact, they do have like a scanning component where, like, if you go to an in-service, it automatically populates into your account, and so they keep up with and you can keep up with the number of continuing education units that you actually have. But if they don't have that mechanism when you go to an event, then you can actually log into your account on the nurses board and actually input your continuing education units, and you have to keep up with those things. But going back, the Nurse Practice Act, it is considered the law. It is our to-do list. It guides what we do. And facilities should derive their policies and procedures from the Nurse Practice Act. They should not be asking us to do anything, provide any care that's not in that act. So ethics is a system of standards or moral principles. It guides us. It tells us, well, we should do this or we should not do that. And it comes up as, is this the right thing to do or is this the wrong thing to do? And so it's an honor system. We're there to provide that best care we can for our clients, and we have to decide to do the right thing. And sometimes you will see or witness wrong things being done, and you have, as ethical, being ethical, you will report that and address that. If one has the right to do something, if one has the duty to do something, so if it's on that Nurse Practice Act, it's lawful for us to provide that best care for that client. And we'll get into these principles here in just a moment, regardless of that client's pay status, regardless of that client's disease process they're having going on, whether or not it's alcoholism or they have diabetes and they're non-compliant, we still have that duty to provide that best care for that patient. So we're getting ready to talk about the different principles. We do need to know the difference in these. Non-malfeasance is not causing harm to the client. And an example of that is when, before we leave out of that room, we're ensuring that that bed is in that lowest position, call lights in reach. We make sure that those things that if they're, like reading magazines or, watching TV, that the remote and those things are in reach. So not causing any harm. The things that we do so that this patient will not receive any harm. We might not think of them as that, but this is why we're lowering those beds, because we don't want any harm to come to our patient. We don't want them to fall out of the bed and break their neck or break a hip or anything like that. They need us. That call light needs to be in reach. In the event that someone has a mobility issue, they don't have hand grip and cannot use this call light properly, then that needs to be an alternate call light provided for that client. Because how will that client call out to us and they don't have the strength or the ability to actually push that button? So that's on us to bring that to the facility's attention, and we provide, that alternate method for them. I've seen call lights where the person actually can breathe into the little tube and it signals the light. There's some little flat call light. They're all different kinds. But the whole thing is non-malfeasance, not causing any harm to the patients. An example is lowering that bed in that lowest lateral position and then making sure that that call light is in reach. So autonomy, look at this right here. Let me go back. So, not that one, but autonomy, auto. This is self. So this is the person governing and making their own decisions. And we do want to support them in that. We're going to make sure they have enough information so that they can, make an informed decision. But if a client decide not to accept medical treatment or medications, then as long as we provided that information for them, we support them in that. Leaving against medical advice. We don't want them to leave but we don't want to persuade them to stay. As long as they've been provided enough information to make an informed decision, we accept that client's right to self-govern. We allow them to sign that paperwork. We allow them to refuse the medication or the treatment. We support them in it. Okay. Justice is the quality of being fair and reasonable, just behavior or treatment. So no matter what our client's ability to pay, insurance, no insurance, underinsured, if they have a history of alcoholism, history of being non-compliant with hypertension, whatever it is, we still provide that same best care for each client. And that is an example of justice, being fair and reasonable to each of our patients. So fidelity, we're acting with integrity and trustworthiness, and we're being professional. And so in the event that, we see our coworkers or overhear our coworkers speaking in a tone that's disrespectful, or, making fun of or belittling, then, we want to remind them about, working and treating everyone with integrity and being trustworthiness. And so, because they're coming to us to provide that best care that they can with whatever situation they have. So they're dependent on us to be professional. And even if that client is needing to be refocused, is a way that we speak, is a tone that we speak in, so that we can, be professional. So you might have to intervene with your coworkers, and it's a way. Each facility will have a process, a procedure that you can follow in the event that you overhear or witness care being provided to clients. It could be the healthcare provider, it could be a dietitian, another nurse. They have policies and procedures, but for the most part, everyone is there to take care of the patients and provide that best care. So you really don't run into this often where people are being disrespectful and making fun of and belittling patients. So beneficent paternalism, it is considered, it's like the opposite of autonomy, because what beneficent paternalism does, it says, I know what's the better option is for you. So an example would be, a scenario would be, we have a parent or guardian, they have a child, and the healthcare provider has presented this treatment option to them. The parents have decided not to take the treatment option. And so the healthcare provider, is just so that they believe that this will make this client's quality of life, better. And so what they do is they petition the court, the healthcare provider. It does not mean that the courts will side with the doctor or the parents, but it's just an opportunity for the healthcare provider to provide the information, the situation. It is used in extreme circumstances about a medical decision. And like I said, it's really the opposite of autonomy. It's considered a disrespectful attitude toward the client and what the client has stated that they want to have done. It's using emergency, extreme situations where that information is presented to the courts. And so it's like telling the client what treatment option they should choose instead of the patient going with the option that they want. So beneficent paternalism is used in extreme circumstances, emergencies. It's going against autonomy. It's telling the client, I know what's the better option for you. And so that information is presented to the courts. So I'm going to stop here and look in the chat, make sure we don't have any questions. Okay, keep moving. I don't see any. Beneficence, which is different from beneficent paternalism. Uh-oh. Okay, let me stop sharing. And so beneficent is doing what is beneficial for the client. doing what is best for that client. And an example that I have here is you might have to question the doctor's orders. If you see that, the medication, for example, if you're administering a medication and you see that it's making that client have a whole change in status. For example, the client takes the medication and they're knocked out. They're not drowsy. They're completely like incoherent. They're hard to arouse. The client initially was continent because of the medication and them being so sleepy and drowsy. They're incontinent. So we might have to call, well, we should call and report our findings, our assessment findings to the healthcare provider with what we're finding out. Well, once we get this medication, yes, their pain is relieved or whatever we're giving it for, but we're also noticing this client cannot even wake up to even go use the restroom. So we might have to question the doctor's orders, and that's doing what's best for the patient. Are we doing anything that's beneficial for the patient? Because sometimes, medications, we might have to go up or on the opposite. We're seeing that a client is being given pain medication and the medicine that is not controlling their pain. Some people are never pain free, but they have some type of pain control is managed. And so the same thing, we may have to question that doctor's order. We're administering this as ordered, but our assessment findings, this client is still rating their pain on a scale of 10 of 10. We see facial grimace, and this client is guarding, this client is moaning, and we still will report that information. So we want to do what's best for the client, what's beneficial for that client. So we have to question those orders sometimes. And we're there all the time with the patient. And so it's on us to report any changes. So malpractice is where the healthcare provider causes harm, there's injury or death to the patient. We're failing to provide that treatment or that action. So it goes back to that care plan. The care plan, for example, that I have here requires 2 persons assist with a person's transfer. But on that day, short staff, we're running behind, whatever the circumstances was, or the nurse just decided, or the CNA just decided, or the unlicensed personnel just decided to go on and transfer this person by themselves. The patient sustained injury. That's an example of malpractice. And so, did we have a duty to that patient? Were we assigned that patient? And then, did we breach our duty? Did we not follow what that care plan told us to do? And as a result of it, was there an injury? And then the thing that we did not do, only having one person, was there a direct connection with the injury that the person sustained with us not following that care plan? So that's malpractice. So there are some things that's reportable. If there are gunshot injuries, we have to report these things to the law. If someone has adverse effects, for example, if we give a medication, usually working in the emergency room or even at the urgent care center, even at the doctor's office, they give someone medication to bring down their blood pressure, or they're given a vaccination, or they're given, something for pain. And we ask the patients to wait that 15, 20 minutes to see if there's a reaction. If there's a reaction, that person starts to develop hives, itching, shortness of breath, we need to report that. It's reportable. And they keep up with that. And then suicidal ideations and a person that's verbalizing a plan, these things are reportable. So you need to know that these 3 things, we have to reveal them. We can't keep them a secret. We have to report this. Even if this person that got this gunshot injury, even if we know that they've been to gun safety, firearm safety classes, were goofing around, or they were cleaning the gun and it went off by mistake, we still have to report it. It is still reportable. Okay. So personal versus professional ethics. As you go through your different clinical sites, be thinking about which settings that you favor the most. Because remember, we're going to go back to the Nurse Practice Act. As long as it's lawful, we can assist with procedures, we can perform procedures, as long as it's on your state Nurse Practice Act. But sometimes the things that are lawful for us to do will have conflict with our personal beliefs. So as you go through and do your observations and go through your different clinical sites, just see which, what is there, what is going to be expected of you if you decide to work there. Even once you do your interview, these are questions that you want to ask. You want to make sure that those responsibility, your task list, that you look at that entire list to determine whether or not are these things that you want to participate in. Because sometimes where personal ethics and your professional ethics, they might bump heads. That might be a conflict. It's lawful for you to do it, but then you personally would not want to participate in that activity that's occurring in that facility. So personal ethics is our guidelines for living. You ultimately choose what your personal code of ethics includes. And then, like I said, just sometimes it bumps head with your professional. A lot of times when you are working in facilities that have several different units or floors, you will be cross-trained. And so even though you're hired to work on that specific unit, but because you're cross-trained, you might be pulled to a different area. So in that area, are those procedures and things that they do, the care that they provide, is that something that you personally have an issue with? So, and if so, will have to talk with your supervisor and or decide if that's the place that you want to work. Because we go to provide that best care we can for our clients. Ethical responsibilities of the nurse. We are that client advocate. If that client is asking us questions and saying, well, hey, what would you do? We want to make sure that client, we don't give advice, but we want more than likely that client might not have a good understanding or may need more information so they can make that a decision. So it's on us to coordinate, call on that healthcare provider, call on that dietitian to come back and speak with that client. Because we're the advocate, we're accountable. And this colleague reporting, in the event that we see or overhear our colleagues doing something that's unethical, that's unlawful, we have to report that, what's right and what's wrong. Okay. And we just went over these principles. Let's go over them again, look at them all at once. So non-malfeasance, we're doing no harm. Beneficence is what we're doing. Is it benefiting this client? Autonomy, that patient has the freedom to choose. And freedom to choose also includes refusing care, refusing treatment. Fidelity, be true. And then justice, fair for all. No matter what my pay status is, no matter what my background is, what disease process I might have, I may be an alcoholic or another substance abuse user, we still are supposed to treat our clients fair. Okay. So more on autonomy, thinking through all the facts, decided on the basis of the independent thinking process, acting based on personal decision. There is self-governing that client, as long as they have enough information so they can make that informed decision. So the legal aspects of nursing care, we talked about the Nurse State Practice Act. From that, the facility that we work in, the organization, they create their rules, their regulations, and their policies and procedures. So in the event that they call 1-800-DIAL-A-LAWYER, you have to appear in court, give a deposition, then they're going to go back to, well, what does the Nurse Practice Act say? Then they're going to link it to, will that facility, did they rules and regulations comply with the Nurse Practice Act? Did those policies and procedures, did they comply with the Nurse Practice Act? So we do need to know that those things all couple with each other. And as the Nurse Practice Act is revised, you may be on that team at that facility to help revise and review policies and procedures yearly, or whatever their system is. At a minimum, facilities go and look at their policy procedures every year. Some may do it a little bit more often than that. But they know that those policies and procedures and those rules and regulations should match this Nurse Practice Act. Because otherwise, we're committing a crime if we're doing something and it does not match. Because and it's not lawful for us to do that. So it's important for us to know our scope of practice. That Nurse Practice Act, can't say that enough, because people will ask you to do, like, for example, even at clinical, you know that there are certain things that you're supposed to do, and your clinical instructor is supposed to be there. But sometimes people will ask you to do things, and they're knowing that you're not supposed to do them because you're the student. You're not practicing on your own license. But it's up to you to know, well, hey, no, I can't do that. I have to have my instructor. Once you get your license, well, no, my Nurse Practice Act says I'm not supposed to be doing this, performing this procedure. It's up to you to say no, even though if they have policies and procedures that's unlawful, then that needs to be a conversation. So you're not exempt from being penalized if the policies and procedures don't match the Nurse Practice Act. So we need to bring that to their attention, have that conversation. We need to know the State Board of Nursing functions. I'm going to read through each of these. Licensing and certifying. So specialty certifications, setting those fees. These some of the fees that you have to pay while you're in nursing school, and thereafter it comes from the Board of Nursing. That board is a group of members or people that help oversee and revise things. So they establish standards of educational programs. They're the ones that go in and say, hey, we have to have so much seat time. Your different classes have different amounts of time. They go in and say that this this class right here should meet for, hour, 60 minutes, 90 minutes. And they also approve schools of nursing. They oversee that part. Then in addition to that, they also look at that pass rate, and then they go back in and they put their stamp of approval on each time. I'm not sure how often they go back in and look at everything, but they do. It's an ongoing process. Once you get approved in the School of Nursing, it's not once approved, always approved. There's still a reapproval process. They come in and look at everything. And also your NCLEX rate is a huge impact on that as well, maintaining that approval. So determining duration and renewal of licensure. Some boards require continual education credits. This is just information, webinars that you can go to. They can be on-site, self-study, and you will have to have a certain number of units or credits for you to renew your license. But you will know that because that state will tell you what is the requirement in order for you to renew your license. And that's just an education piece. We're life learners. Because we're providing that evidence base, that latest evidence base information. So there's always information that you can update on it, especially if you get certifications in different things, then you're going to want to make sure that, that kind of guides your continuing education credits, because there are continuing education credits about everything out there. So, especially if you're certified, you want to link your continuing education credits to those certifications, because in order to maintain those certifications outside of your nursing license, you have to have so many education units of staying on top of things, being refreshed with the latest evidence. So they maintain that inactive status list, carrying out disciplinary actions for violators. So in the event that nurses are impaired or something has happened, they have programs. They're the ones that oversee that disciplinary process. A nurse may have to go in and do drug testing every so often. They may have to come in and do some extra education units. So they oversee that process. Also, they oversee suspending and revoking or taking away license and dealing with the appeal process. Okay. So there are 8 categories that can result in disciplinary actions. So you would think, well, we're providing the best care for our patients. What in the world? Yes, things can still happen. Criminal activity, negligence, unethical conduct, a person being incompetent, they may be impaired and they still come try to provide care for that client. Client end up with an injury and alcohol and drug abuse. So if you're assigned patients, you want to make sure that you are administering those medications to those clients because if medicines come up missing at the end of the shift or whenever you do your count, then you're solely responsible for those medications. So you want to just be careful with that. There have even been instances where people have stolen the patient's identities, all different types of things actually happen. And so, even though we're supposed to be there providing the best care, the most trusted profession, things still do happen that are not good. So, in the event that something goes wrong, what happens next? Those disciplinary steps, we need to know these. A complaint is filed at the state board. That complaint is reviewed. There's an investigation. And then during the board proceedings, this is when we, the nurse, have the opportunity to respond. Okay. That's when we have the opportunity to respond because usually there's a complaint. The complaint is reviewed. They have to do that investigation. And then during those board proceedings is when we have the opportunity to tell our side or tell what happened. The board action, they may decide to immediately suspend licensure. There are different actions that they can take. Remediation, there can be fees that you have to pay, disciplinary actions. And then depends on what happened, your name may be placed in these databases. And these are, I like to think of as a huge file cabinet that stores information with people, healthcare professionals that had some type of disciplinary action. So what happened before they created this data bank? People were able to move around and from state to state or job to job, and no one knew that they had any type of disciplinary action on them. They never knew that they were suspended. But people were doing that, and it was like, well, we got to come up with something so that no matter which state you go to or which facility you go to, we have to have a central location where you can type the person name in, and if they're in there, you can see what's going on. So this is where this national practitioner data bank or this is where these databases do. They keep up with that. So whatever it happened at that job, somebody's job task to place this information in these databanks. And so if that nurse goes to whatever state or whatever the next job, then they will know. Because there's been plenty of times before they created this when people were going place to place and they were under disciplinary actions. Their license had been suspended or even revoked, but they were still providing care because no one knew that they were under investigation or disciplinary action had been taken against them that had taken their license. And so this again, the National Practitioner Data Bank is a data management system to track unfit healthcare practitioners and restrict the ability of incompetent professionals to move from state to state without disclosure of whatever happened with them. And so this data bank, they type the name in, name pops up, and that's part of your onboarding anyways. That person now, what they do is they go and look in that National Practitioner Data Bank. That's part of onboarding. So all state boards of nursing, they're mandated to report disciplinary actions, including probation, suspensions, and revocation of nursing license to this ENPDB. And I just, like I said, think of it as a huge file cabinet that keeps all of this information. So when we look up a nurse, the only thing that's there is their license number, of course, their name, but their license number, the date that license expired, and whether or not they have any disciplinary actions. If we look up a nurse, it shouldn't tell us where they live. It should not be giving us their date of birth. It shouldn't be telling us places that they work at, income, or any of that. That this verification system lists, of course, our name, what the license number is, the date that that license expired. And so this is where that CEUs, those continuing education credit units come in at. And this keeps us our license current. And then if that person has had any disciplinary actions. So I am going to go back to the first couple of slides here because our time is about to run out. So remember, all of this content you'll see next week again, and then also the next week on that exam. So let me share my screen again. So the Nurse Practice Act, tell me two things about it. What do you remember about that Nurse Practice Act? You need to know it is our to-do list. It's guided by state statutes. It's considered the law. It is a guideline that tells us what we can do and not do. And you can reword that however you need to. Ethics, what is the right thing to do? Well, if this is the wrong thing, I don't need to do it. So it's that moral principles that direct us as we shouldn't be doing this or we should do this. Non-malfeasance, not causing harm to that patient, making sure that bed is in the lowest position and that call light is in reach. That if the call light, the person can't demonstrate correct use of it, we get a different call light. In the event that this patient has a history of, falls, you may see beds that are really like on the floor. You may see mats, but nevertheless, we want that bed lower because we don't want any harm to come to that patient. Autonomy. We support that client, that patient in self-government, them making their own decisions, even if that means they're refusing care or treatment. They're leaving against medical advice. They're leaving the hospital. They're in a facility and they're deciding, well, I don't want that medication. They have the right to self-govern as long as they have enough information to make an informed decision. Justice, we're providing the best care to everybody, no matter what their pay status is, no matter what their background is, history of alcoholism, history of non-compliance for hypertension. We still provide that best care. Fidelity, we speak up in the event that we hear or oversee someone not doing what they're supposed to do for a client. They're not being professional. They're acting, not with integrity. We speak up, but we want to be trustworthy. We're the most trusted profession that it is. I mean, I don't know how many years in a row we've been voted that. So we do want to act with integrity. We do want to be honest with our clients. We don't want to be laughing, making fun of, and belittling anyone. Beneficent paternalism is the opposite of autonomy. It is where the healthcare provider says, hey, I know what's best for you. The parent or guardian or the client have made a decision about their healthcare. That healthcare provider decides to petition the court. And does not mean that the courts will side or go with what the healthcare provider wants, but it just means that they are given the opportunity to present everything. It's only used in extreme circumstances, emergency situations. But it is telling the client what treatment option they should choose, what's best for them. Beneficent is what we're doing. Is it the best thing for that client? We have to question those doctors' orders sometimes. Their pain is not being controlled. The medication that they're being given, the blood pressure is not being controlled. So we have to call and report our assessment findings. And malpractice, the patient sustained some type of injury or harm because we did not follow that care plan. The person required 2 persons assist. We decided to just do it ourselves. The person needed 1 person to accompany to activity. We told the patient to go on because we had to take a phone call. That patient ended up falling. and sustaining some type of injury. That's malpractice. Okay. Reportable. We have to report gunshot injuries. Even if that gun belonged to that client, they were cleaning it, something went wrong, they were not trying to do it, we still have to report it. Any adverse effects from giving medications, suicide ideation with if they have a plan. Gonna stop here. Do we have any questions about any of the content that we went over? Okay. Any questions?